Hi, I'm Dr. Stephen Daugherty. I'm here to talk a little bit about the venous causes for chronic pelvic and abdominal pain. This is important, and until recent years we really didn't have good means of diagnosing these problems, but now we do have reasonable means of diagnosing these problems in some patients who are just miserable in many cases. You can have problems related to venous obstruction or venous valve failure in the pelvis, causing symptoms that are fairly similar. In either case, it's pain due to high pressure in the pelvic venous system with inflammatory changes associated with that pressure. If you think about it, reflux of blood from the level of the kidneys down to the pelvis does not cause a great deal of pressure in the pelvis, but it can cause pain for a few patients. But more commonly, the problem is obstruction of veins in the pelvis, causing arterial flow that's passing into the legs and pelvis to then back up under very high pressures in the pelvis if there's a significant obstruction present. Symptoms can range a lot from labiovaricosities occasionally, varices coming out of the labia or infragluteal or at the groin, into the leg or the suprapubic areas. There may be bladder symptoms, but more commonly with pelvic venous problems, there is dyspareunia. It's deep dyspareunia, and it's often associated with postcoital pain here. Sometimes the pain is low back pain associated with collaterals in the low back around here, with veins under pressure carrying blood flow around the obstruction, and these veins go into the paraspinous area and cause quite a bit of pain, which may not be relieved any other way than to treat the obstruction. Now, there are many different things that can cause some of these symptoms, and obviously the gynecologists are thinking about problems with the uterus, fibroids, hemometra, adenomyosis, endometriosis, ovarian cysts, chronic PID, those sorts of things. All of those are very real. Many of them you can detect with ultrasound or laparoscopy or both. Not all of them, but those are often things that one can sort out and exclude. If they're not really obviously the source of the patient's pain, one has to look at other things. An important part of evaluating these patients is to evaluate their pelvic venous system. Most of the time that can be done in a very skilled venous laboratory with vascular ultrasound. Often these are missed with CT scans and MR scans that are not specifically performed to look closely at the venous system in the abdomen and pelvis. So patients may come in with pain in this part of the body. They may also come in with left flank pain, and they may have hematuria associated with issues with the renal vein. But let's talk about what we see in these patients. We do ultrasound in these patients who are having these symptoms, and if we've reasonably well ruled out a gynecologic source for the pain, ultrasound of the abdominal and pelvic veins to evaluate flow, vein diameter, and to look for collateral flow around obstruction can be very useful. We look at the peak venous velocity across the lesion in the pelvis. We look at the ratio between the venous velocity across the lesion and that below it. And we look at those ratios to sort out whether this may be hemodynamically significant. Now, there's no one criterion that absolutely gives you the answer about what's going on, but in reality we're looking at multiple different lesions. This shows the iliac venous system, the external iliac vein here, internal iliac vein, common iliac vein, and on the left there may be compression of the common iliac vein by one or two arteries most commonly, though there's a lot of variability to this. The vertebral body is posterior to this vein. These arteries pass in front of the vein, compressing the vein up against the vertebral body, which can cause a long, narrow stenosis in some cases. If we see flow coming up in the external iliac vein and then passing retrograde in the internal iliac vein across the pelvis, we know there's an obstructive lesion present. Also, if we see an ascending lumbar vein here in the retroperitoneum carrying this blood around blockage, we know there's a lesion here in the common iliac vein. So those are important parameters that we use to sort this out. That should be done fairly early on in the evaluation of patients with chronic pelvic pain, so that we're not missing these lesions and delaying appropriate care for the patients. So when we evaluate these patients, we also evaluate the renal veins and gonadal veins, because sometimes a left renal vein stenosis, for instance, can be the source of the patient's chronic pelvic pain. We were all taught in medical school that a renal vein stenosis may cause left flank pain and hematuria. Well, often that's not the case. Often there are collaterals that allow flow away from the kidney that don't cause left flank pain and don't cause hematuria. Most of these patients have retrograde flow in the gonadal vein. Normally the gonadal vein drains this way to the left renal vein and then drains into the inferior vena cava. If there's an obstruction here at the central renal vein, as is shown here, the renal vein typically is compressed between the aorta and the superior mesenteric artery, limiting flow out of the renal vein. So that flow has to go somewhere. And if this is tight enough, then that flow may go up through the hemiazygous vein in the chest, or more commonly down the gonadal vein into the pelvis. So we'll see retrograde flow in the left gonadal vein, not uncommonly a dilated left gonadal vein. And then the question becomes one of, well, is this an obstruction of the renal vein that's causing this, or is this just a dilated gonadal vein that's a problem with reflux down here? And as we get more sophisticated in evaluation of these, we're finding more often that these are actually renal vein stenoses that are causing flow down to the pelvis. The interesting thing is that there are a fair number of women who have severe arterial compression of the common iliac vein here and compression of the renal vein here. And if that is the case and their problem is chronic pelvic pain, stenting the left common iliac vein here will often solve their pelvic pain. It's very effective in properly chosen patients at solving their chronic pelvic pain, their deep dyspareunia. And most of the time, these renal vein stenoses do not need to be treated. There are a few that do need to be treated because the flow down here through the pelvis is just not enough to solve the problem. And there's still venous hypertension in the pelvis with this flow coming down this way. And in those rare cases, then transposition of the gonadal vein from here over to the inferior vena cava, or transposition of the renal vein to get it out of that notch over here, is helpful to those patients. So it takes very careful selection and very careful study of the anatomy and physiology with ultrasound and with venography to evaluate this. But there's an important subset of patients with chronic pelvic pain who can be helped tremendously by identifying this problem and treating it. Some of these patients also have vulvar varices that extend into their legs, and if they're not having pelvic pain, it may be that all they need is ultrasound-guided foam sclerotherapy in some of these veins in the thigh and in the vulva up here to solve that problem if they're symptomatic from their vulvar varicosities. But those that have chronic pelvic pain, we need to be looking for the source of the venous hypertension in the pelvis up here. Now, sometimes we don't find that, but the vast majority of patients who tell us they have deep dyspareunia and pain after intercourse will turn out to have an iliac venous obstruction here at the very least. Once we suspect that the patient's problem is a pelvic venous problem and ultrasound has shown us more about the anatomy and physiology, the next step in the patient who's not had previous thrombosis usually is to go ahead and do venograms and intravascular ultrasound. The venograms most commonly are done through bilateral femoral vein sticks here with injection of contrast up through the iliac system. We follow it to the heart. Most commonly we see the stenosis in the common iliac vein venographically, and we see some reversal of flow across the internal iliac vein and through the pelvis. Sometimes we see the ascending lumbar vein, which comes off here in the retroperitoneum, that is serving as a collateral. We also use intravascular ultrasound it's a catheter that we pass through the femoral, up the iliac, and across that to the heart. We pull the catheter back, and we actually measure the cross section across this vein so that we can see the diameter of the vein, we can see the wall thickness, we can see the shape and length of the stenosis, so we can sort out the likelihood that this is hemodynamically significant and make decisions about whether to treat, second, what size balloon stent to use for treatment, and finally, to make sure as we finish treatment that we've treated all the segment of vein that needs to be treated. That's an outpatient procedure. Most patients go home 2 hours later and they do quite well. The small number who still have significant pain most commonly have a renal vein stenosis up here that then needs to be treated, and we typically observe those patients for several months before recommending additional treatment to give them time for the pelvis to improve from the chronic venous pressures and inflammatory changes as much as possible, and then suggest the various methods for decompressing the renal vein if it's necessary to do so, as I mentioned previously. I want to briefly show you venograms in addition to the ultrasound that we've already done, both transabdominal and in cases of pelvic pain endovaginal, so that we see the varices in the pelvis. We then do venograms. You see a contrast injection in the left external iliac vein with flow coming up the external iliac here. It crosses the pelvis from left to right and then starts to fill these other veins in the right adnexal area. And we'll have another run here to show you just a moment. Here's another injection. Right here is the obstruction. You don't see contrast there. There should be a lot of contrast there. Instead, it goes across the pelvis and then over to fill the right iliac here, and then back up this way, up the right iliac system. Now, we'll look at another venogram. This is a renal venogram. This is the injection at the renal vein. This is the renal pelvis, but these are renal veins here. This is a serpiginous collateral vein. Anytime you see those, they suggest obstruction with those little serpiginous veins trying to get around it. And you see here, this is flow going retrograde down the ovarian vein into the pelvis. There's very little flow going here, as it should, through the renal vein into the inferior vena cava. So nearly all the renal blood flow is passing down the gonadal vein into the pelvis, causing pelvic pain. These are those serpiginous veins here, and if you look closely at this, you can see there's a shadow here. This is flow coming back up the right ovarian vein and back to the inferior vena cava here. So this flow goes from the renal vein, left renal vein, down the left ovarian vein into the pelvis, across the pelvis, back up the right ovarian vein to the inferior vena cava. And this is the same patient. This is an injection in the gonadal vein here in the false pelvis, with flow that goes down into the left adnexal area, across a uterus that's somewhat asymmetrically positioned. These are periuterine veins, into the right adnexal veins, and then back up this ovarian vein here, back up to the cava. So these veins, distended with all that renal blood flow, cause pain, and with exercise the patient has more pain in the pelvis because of the increased heart rate and increased cardiac output. There was a lot of excitement in the early 1990s about ovarian vein reflux as a cause for chronic pelvic pain. That actually is a cause for chronic pelvic pain in an occasional patient. In our experience, it's a very unusual patient where that's the real cause of pelvic pain. The ovarian veins can dilate, and that may be primary dilatation with valve failure in those veins, with thin blood that just refluxes from the renal or from the inferior vena cava on the right side down the gonadal vein into the pelvis. Sometimes it's because there's an iliac vein obstruction up here, and the ovarian vein is an important outflow pathway at times when the patient is actively exercising, so that the vein dilates. And in that case, if one occludes the ovarian vein, then the patient may get worse with exercise. If there's a renal vein stenosis here that's the reason for reflux down the ovarian vein, and if you obliterate this ovarian vein, then the patient will develop flank pain and become miserable. We've seen some of these patients who have awakened in the recovery room after they were treated at other institutions for a dilated ovarian vein, which was ablated, and then it became obvious that their problem was a missed renal vein stenosis up here. So it's very important to be sure these stenoses are not missed. So the treatment for ovarian vein reflux, when it's really reflux and not obstruction, is to run a catheter down the ovarian vein, inject a contrast agent along with a sclerosant to fill many of these pelvic varices here, because to get them to sclerose down, and then to place coils, metallic coils with a little bit of fabric on them along the ovarian vein, sandwiching it with sclerosant injections along here to get this vein to seal shut. In practice, for us, it's an extremely rare patient who actually needs that treatment. There are some who believe that that treatment is great and wonderful, but we just don't see very many who need it, but the occasional patient really truly does. I think a lot of the reason that some are skeptical about pelvic venous disease causing pelvic pain is that there have been too many patients with failed treatment because they had ovarian vein ablations done when that wasn't the problem. If you don't treat the right problem, your patient doesn't get better. There's a rare patient also with compression of the inferior vena cava high up near the diaphragm. It's called median arcuate ligament syndrome. These patients are rare, but sometimes there is enough of an anatomical compression of the inferior vena cava up here that it will actually cause backup of venous blood through most of the abdominal and pelvic venous system, with all kinds of symptoms ranging from leg symptoms to abdominal and pelvic discomfort and bloating. I've not mentioned previously the leg symptoms that occur due to these iliac vein obstructions. The early studies done on these patients with iliac vein obstructions were all about leg pain and leg swelling. It can affect either leg. And we began to realize about 15 years ago that some of these patients with leg pain and leg swelling that we were treating with these iliac vein lesions also had chronic pelvic pain that resolved when we treated them. That's how we came up with the series of patients that we treated and could document that this is a very real entity. Since we initially documented this and reported it in 2013, there have been a number of centers around the world that have found exactly the same thing, that iliac vein stenosis obstruction is the more common venous cause for pelvic pain and often a cause for lower extremity pain and edema. Lower extremity symptoms are not critical, though. Some patients have very little, if any, lower extremity symptom or very subtle lower extremity symptoms. So you don't have to have pain everywhere. You can have pain and discomfort anywhere from the foot all the way to the level of the low back associated with these iliac vein lesions. And of course, with renal vein obstruction, it can be flank pain or pain in the pelvis. So if you have a patient where you don't have a clear-cut gynecologic cause for chronic pelvic pain, it's easy to get a good color duplex ultrasound study of the abdominal and pelvic veins done to sort out whether there is a venous cause for the problem. It's a very specialized study. Our office is the only place in Middle Tennessee that we know of where you can really get a high-quality venous color duplex ultrasound study of the abdominal and pelvic veins to study the things that we want to know when we're evaluating these patients. It's very specialized, and we have techs who are very, very good at this who teach it nationally. But get the patients to us, let us evaluate their symptoms and whether the symptoms fit with venous disease, and then do the ultrasound study to sort things out. Occasionally we need other diagnostic studies like CT or MR, but a routine CT or MR will usually miss the problem because they're not really done with a technique to show the problem.
Thank you for taking time to watch this video. We have more educational information on our website, TennesseeVeinCare.com. If you have any questions or you have a patient you would like to refer to our office, please call 931 931-213-7089. That's 931-213-7089. Thank you.